A seizure is a transient clinical event. It is the direct result of abnormal, excessive, and synchronous neuronal activity within the brain. Experiencing a single event does not mean a patient has epilepsy. Epilepsy is an enduring chronic condition characterized by a permanent predisposition to unprovoked seizure recurrences. This chronic vulnerability is driven by epileptogenesis, an underlying process that structurally alters neuronal networks and permanently lowers the brain's threshold firing. Making clinical sense of these events requires grouping them strictly by the brain's physical architecture, identifying exactly where the cellular imbalance initiates. The 2017 ILAE matrix maps boundaries, sorting seizures into focal, generalized, or unknown onsets. Discarding terms like simple and complex, it relies on observing if a patient's awareness is intact or impaired. Finally, it divides these into motor and non-motor categories. Effectively treating a patient requires identifying the exact scale and location of the electrical network involved. This diagram shows the etiologic triad, a visual scale representing the delicate balance between neural excitation and inhibition. 3 variables dictate whether a seizure will occur. Endogenous factors, such as a patient's genetic seizure threshold and maturational age, establish the physiological baseline. Long-lasting structural changes, epileptogenic factors, combine with acute precipitating triggers, like sleep deprivation or metabolic stress, to tip that balance into a clinical seizure. The disruption usually starts small. A discrete, localized network of neurons within a single cerebral hemisphere begins to fire synchronously, creating a focal seizure. If the surrounding inhibitory networks fail to contain it, this localized firing gains momentum, breaching structural boundaries and crossing the corpus callosum. The instant this abnormal electrical firing rapidly engages neuronal networks distributed across both cerebral hemispheres, the event escalates into a generalized seizure. The degree of this physical network expansion dictates the exact symptoms the patient will experience. Focal network activity in the primary motor cortex translates directly to specific involuntary movements on the contralateral side of the body. If the abnormal firing spreads sequentially across the motor cortex, the physical symptoms progress along the limb in tandem, a phenomenon documented by neurologist Hewlings-Jackson, now known as the Jacksonian March. When focal seizures originate in other lobes, the manifestations are non-motor. Patients experience experiential auras, distinct phantom smells, or perform involuntary automatisms like lip smacking during periods of impaired awareness. Following the exhaustion of these focal networks, patients often exhibit Todd's paralysis, experiencing localized, temporary weakness in the affected region. When the networks are generalized, the clinical phenotype shifts. A tonic-clonic seizure presents as an abrupt, violent sequence, total muscle rigidity followed by rhythmic clonic jerking. By contrast, typical absent seizures present as a sudden, brief lapse of consciousness. The patient ceases activity and stares, but maintains perfect postural control without collapsing. These generalized presentations map to specific epilepsy syndromes. Juvenile myoclonic epilepsy appears in early adolescence with bilateral muscle jerks, whereas Lennox-Gastaut syndrome presents with multiple, severe seizure types driven by diffuse neuronal dysfunction. Every chaotic physical symptom provides a reliable external readout of the patient's internal network geometry. The diagnostic process begins by ruling out exogenous triggers. Metabolic derangements like hypoglycemia or exposure to toxins must be eliminated before an epileptogenic network can be assumed. Once metabolic causes are excluded, physicians use a routine interrectal EEG to track the invisible electrical networks between seizure events. This simulated EEG readout highlights the exact electrophysiologic hallmark of a typical absent seizure, a burst of generalized, symmetric 3 Hz spike and slow wave discharges. In Lennox-Gastaut syndrome, that pattern devolves into slow spike and wave discharges below 3 Hz against a chaotic background of diffuse electrical activity. Because focal seizures can originate in deep regions like the inferior frontal lobe, the EEG may not capture the source. A high-resolution MRI scan is therefore required to accurately locate the specific structural abnormality. This axial MRI visualizes hippocampal sclerosis, a clear structural lesion. Finding this atrophy confirms a diagnosis of mesial temporal lobe epilepsy, a syndrome notorious for focal seizures with impaired awareness. For pediatric syndromes where MRI shows no structural lesions, genetic testing is increasingly used to identify precise mutations in ion channel genes. Combining the clinical history with specific EEG signatures and high-resolution imaging reliably isolates the exact network defect driving the disorder. Clinical management relies on a strict order of operations. The immediate first step is to identify and remove any acute precipitating factors. When initiating chronic anti-seizure medications, pharmacological choice is strictly dictated by the onset network classification, focal or generalized. Applying the wrong medication mechanism is extremely dangerous. In Dravet syndrome, driven by mutations in the SCN1A sodium channel gene, administering sodium channel blocking medications will exacerbate the seizures. If a focal network is medically refractory, structural lesions offer a clear target. Resecting a scarred hippocampus can halt the seizures in mesial temporal lobe epilepsy. For diffuse, bilateral networks, like those seen in Lennox-Gastaut syndrome, localized surgery is impossible. These patients require implanted neurostimulation devices to modulate the widespread electrical activity. Effective treatment requires targeted intervention, strictly determined by the physical boundaries of the seizure network. When epileptogenic networks remain uncontrolled, the physical risks scale rapidly. Atonic seizures, characterized by a sudden loss of postural tone, carry a massive risk of severe blunt head trauma from immediate drop attacks. During a prolonged generalized tonic-clonic seizure, the physiological breakdown is severe. Respiration is impaired, secretions pool in the airway, and cyanosis develops as the body is starved of oxygen. If the neural network fails to self-terminate the electrical storm, the patient enters status epilepticus, a critical neurological emergency requiring immediate intervention. Similarly, focal motor seizures can lock into a highly refractory state called epilepsia partialis continua, firing unabated for hours or even days. Left unchecked, a transient electrical inconvenience rapidly transitions into permanent physiological brain damage. Diagnosing and treating a seizure disorder is the clinical act of reverse engineering the brain's electrical networks. The network classification, whether the electrical misfire is focal or generalized, dictates the precise physical symptoms the physician observes. Those clinical observations directly predict the diagnostic data required, pointing the physician toward specific EEG patterns or structural defects on an MRI. The resulting diagnostic data leaves only one logical treatment path: localized resection, broad pharmacological intervention, or neuromodulation. The path from a patient's chaotic symptoms to a targeted treatment relies entirely on classifying the network first.